Hi, everyone, and welcome to our webinar this evening. Today's webinar is being hosted by the Southern African region of the Global Mental Health Peer Network. Today's discussion affects many of us directly or indirectly, as addiction is fast becoming one of the greatest mental and physical health concerns globally. The Lancet Commission published an article on this topic, and to draw from it, it stated, few diseases can compete with addiction in their capacity to generate misinformation, misjudgment, or misunderstanding. Illicit drug use has been around for as long as drugs themselves, but the acceptance of addiction to any substance as a disease rather than a choice is a far more modern concept. As the problem of escalating misuse of prescription drugs shows, prevention and treatment of prescription drug dependency offers challenges that differ from those of addiction to illicit drugs, and they need innovative solutions. Addiction is a complex disease without a universal policy approach or treatment. I also saw something recently that really resonated with me around this topic specifically. Often we believe that the solution to addiction is sobriety, where sobriety in many ways is the desired outcome, but the solution is in fact human connection. In today's discussion, we will hear the lived experiences and expertise of three of our members who not only have first-hand experience around this topic, but who are mental health leaders in their own right. Please note that today's discussion contains descriptive information about substance abuse. Just some shopkeeping for all of us. If you have any questions or comments during the webinar, please feel free to use the chat box. Otherwise, we will have an open Q&A section at the end of today's session. Right, so now just to jump straight into it, because I'd like to obviously highlight our presenters today. Firstly, I'm Sandra Ferreira. I didn't even introduce myself. I'm the Global Manager of the Global Mental Health Peer Network. And as I mentioned at the beginning of the introduction, we have three presenters who are also part of our country leadership committee. So I'd like to shoot straight on to Numan. If you can just introduce yourself, please, and where you are from, and just a little bit about yourself.
Hi, everybody. I am Numan Miah. I am based in the UK. I have been with the organization for just over 2 years, actually, and I have done a great deal of work with the organization. I've done a number of, holy moly, what is going on with my camera? Sorry. Let me start again. Sorry about that. I've done a number of presentations with the organization. And you notice I'm turning my camera off, it's been weird. Anyway, so I've done a number of presentations with the organization. I'm a law double postgraduate, but throughout the years I have taken quite an enthusiastic and an impassioned approach to mental health, and this is what has attracted me to the organization, and I've taken quite a bit more of a concerted approach. I have taken a bit more of a concerted approach to advocating for a great deal of things, and this isn't my first presentation, and by all means, I certainly hope it isn't my last. And today I will be discussing about my struggles and my recovery from drug addiction. So without further ado, I will do my presentation.
All right, before you do that, let's just introduce the others. Thanks, Numan.
No problem.
All right, if you feel more comfortable, or if it's going to be easier tech-wise, you're welcome, obviously, to switch off your camera. Does seem like it's got some creepy crawlies in there somewhere. All right, Marcel, if I can ask you just to do a short introduction, your name, where you're from, and a little bit about yourself, please.
Yes, thank you. Welcome, everybody. I'm Marcel Niezen from the Netherlands. I'm vice chair of the Dutch Association of Experts by Experience, and joined the GMHPN 2 years ago. This is my second webinar, so I'm looking forward to it, and I will introduce myself later on some more.
Fantastic. Thank you, Marcel. All right, then last but not least, Elsa, if you can just tell us who you are and where you're from and a little bit about yourself.
I'm Elza. I am from Cape Town, South Africa, and I actually only joined in March this year. And this is my first webinar with you guys. And yeah, I'm super excited. So I have lived experience with substance abuse and an eating disorder. And yeah, that's my lived experience, and also struggle with mental health issues and deal with them on a daily basis. So yeah, that's me.
Fantastic. Thank you, Elsa. All right, Numan, we're going to go back to you. And if I can ask or pose the first question for this evening or this morning, wherever you're dialing in from. Numan, what is your experience with addiction treatments, and were you willing to go into treatments?
Okay, wait, you asked. What was the first question? Sorry.
What is your experience with addiction treatments, and were you willing to go into treatment?
My experience, I'm going to try with video again because it keeps on jumping. So let's see what happens. My experience with addiction is I messed around quite a great deal with cannabis, but my first experience with addiction was with opiates, with codeine, tramadol, dihydrocodeine. And I started when I was 16, and I'm 30 now. I stopped when I was about 27. So I was messing around with that sort of stuff for 11 years. By all means, I knew it was a problem, but I also knew that if I mentioned anything, that I would kind of lose my abilities or my capacity to actually get anything. I knew how the whole addiction treatment system worked. It worked on the modality of, am I a risk to anyone? Am I a risk to myself? Am I homeless? Am I from a low socioeconomic? Am I at risk of self-harm or anything like that? It wasn't necessarily, it was more about preventative. It was more based around preventative measures, less about why am I doing it? And I did mention once, whilst having a straight conversation with a pharmacist, yeah, I do use codeine and what have you, but it didn't go any further than that. And pharmacists do have the capacity and they do have the knowledge to actually signpost, but it didn't go much further than that. Even with a more recent conversation with a physician that I did talk about my addiction problems, and they talked about, do I have any more cravings or anything like that? They didn't go any further into why I did it. It was less about, am I going to do it again?
I think that's very valid. And it's often that the causes are looked at and not the symptoms in many ways. I think that links into the second question. We can maybe crack that one open a bit. And did your past trauma play a role in your addiction? And do you feel like it was dealt with, be it in the treatment that you've had previously or the treatment that you're having currently?
You went a bit silent there. Did I, what in the who knows, and then treatment something?
Okay, no problem. Let me repeat. I was saying, just a comment to your answer to the first bit, that often it is the situation where the symptoms are looked at and the causes are not always addressed the way they should be. So to link in with that, did past trauma play a role in your addiction? And do you feel like it was dealt with in the treatment that you received or the treatment you are still receiving? Is your trauma being dealt with?
No, my trauma is still very much so that it's still very much so strong and very much so alive, but I don't entertain it. I don't numb it with illicit substances anymore because I was using it as a means of escape. It was an escapism. It was numbing me. It didn't heal me. It didn't have any restorative effects. It was just a way for me to leave the problem. But once I came back down, once I was sober, the problems were still there. And once I came back down, I would just use again. And I would use again and again and again and again. And as my tolerance grew more and more, I would use even more. And I wasn't ignorant about how it was impacting my body. I knew my body was falling apart. It was falling apart greatly, and opiates can lead to you having breathing problems, and cannabis can lead to massive, great deal of, respiratory problems. Both of them were essentially downers. I could have had a massive heart attack. I could have stopped breathing one day, but I didn't care because I felt happy, and it was a manufactured sense of happiness. And truth be told, yes, I know this is about recovery, but this doesn't deny the fact I loved it. And I loved it at the time. But I also hated the person I became. I don't remember much of anything from that time. The only way for me to remember anything is for me to look at the pictures. And it's like a snapshot of everything that happened.
Okay, thank you for sharing. And Numan, you are very honest, obviously saying how, how it made you feel and such. And it's very important to be honest, with our feelings. It doesn't even matter if it was something obviously that was difficult to go through, but to recognize and to be honest and say that you actually did love it is very important as part of acceptance and acknowledgement of, whatever we may be going through. This one, I know you've been looking forward to this question, and I've been looking forward to the answer on this one as well. For your law dissertation, you researched different treatment models that are used around the world. Can you tell us a bit more about this, and also which ones you think are the most effective from a global perspective?
All right, okay, I'll answer the first part one, because that one is the one where I can be the most descriptive one, and it's probably the most boring one. So I'll go for that one quickly. The UK uses a criminalized model, which is by far and away the most commonly used model in almost every country, aside from Portugal and Amsterdam, part of Netherlands, and certain states of America, Uruguay, and certain parts of Canada and Thailand. There's a couple of different facets of society, and then it has by and far and away been a catastrophic failure. Not even my words, it's the words of many social legal scholars, criminologists, and what have you. It has been a gigantic failure. It just simply does not work. There's still drug misuse problems. There's still people buying drugs from the black market. I mean, an easy way to look at it is I did it. And I did it for years. It was easy. It's so easy. I could still go around the corner and buy drugs from someone from around the corner on the street. It does not work. It just really does not work at all. And then you've got the legalized model where all drugs are made legal, which is and Uruguay is the only one that has used that. That one, there's still a lot of contention behind that one, because Uruguay has its own, because of its political climate, we still don't know a great deal about how it has worked. But then if you look at Amsterdam for its legalized model of cannabis, it has worked quite well. And there isn't a great deal of drug addiction issues for cannabis. But for like hard drugs like crack cocaine and heroin, whatever, that is a different thing. Now, the special one, the unique one, the true gem in all of this, Portugal, which has taken a decriminalized model where it means, yes, no drug, every drug, yeah, it's not legal, but it's treated more so as a health issue. Yes, if you're caught with a certain amount of drugs, yeah, something will be done to you. You won't go to jail, but you will go in for treatment, and it is seen purely as a health issue. It is no longer a criminal issue, because they look at what is going on in your background. Why are you pursuing it? What is going on in your family life? What is going on in your personal life? What is your background? What is your trauma? How are you able to also feed this habit, despite the fact that it is such an exorbitantly expensive lifestyle? Why are people still doing this? At the end of the day, with most drugs, it changes your mentality and how you perceive life. It is a complete change of how you view the world. And that's not even just for hallucinogenics. with something like opiates, one of the side effects is euphoria. Euphoria is a sense of extreme happiness. I mean, who doesn't want that? But you know, that's manufactured. It's a manufactured happiness. So they look at what can be done for these people. How can they be best treated? What do they need? Is it employment? Is it education? Is there something going on in the house? Is it domestic abuse? Is it psychological, emotional? That's what it does. It has been a massive success. Yes, by all means, there is still drugs in the country, but it is being treated as a health issue. And that's what has worked. And the fact that other countries have not taken that as for what it is, that it works, it is a bit of a blight. So the decriminalized model is a massive, massive success.
Thanks, Numan. That's super interesting. And as you say, I know you love it, and I love that you love it, and we can learn from it. It is interesting because it kind of links in with what my intro, that addiction to any substance is the disease of addiction is a modern concept. So the Portugal's angle is kind of, they're seeing it as a health problem because it's it's not just a choice or a social issue, but it's an actual health problem. And I think with approaching it like that as well, it helps a tremendous amount with the destigmatization as well, I would assume. The knock-on effect of throwing it under the umbrella of healthcare must be massive. I actually do want to look into that a bit more. And having Portuguese roots as well, I'm quite proud, I have to say. So that's really wonderful to hear. Thanks, Numan. Really appreciate your inputs and your knowledge and your expertise around this, really. So thank you so much for your inputs tonight. We will probably come back to you during the Q&A. So thank you.
No problem.
All right. Marcel. All
Yes.
right. Marcel has a presentation for us that he would like to share on treatment care for addiction in the Netherlands and his peer experience. So Marcel, the floor is yours. Thank you.
Thank you very much, Sandra. Is everybody seeing the presentation now?
Yes.
I see some
Yes,
notes.
we can.
Okay. Okay. Yeah, for me, months go by without me speaking English, so I need a little help for the words. So, 2 months ago, I started as coordinator volunteers at VNN, and VNN is addiction care. Before that, I worked 10 years in mental health care. I'm also a lecturer at Hanze University, where we have a course, 2 years course to become an expert by experience, associate degree. As I said in the beginning, I'm vice chair of the Dutch Association of Peer Workers, and we also founded a collective of peer workers. I am a social worker, but I'm a peer worker since 2008. My personal experience is 20 years of gambling and cocaine addiction, crack cocaine or freebase, I don't know what you call it, we just smoked it. From my 15 to my 36, I'm 53 now, so 16 years clean. And I was for almost 3 years hospitalized in the nice building. They call it the Berk in the Netherlands, almost a castle-like thing you see on the picture. And that was a therapeutic community. 50 other people with an addiction stayed there, and it was all about getting confronted by your peers on your addiction behavior. And when everybody says the same thing, you might want to reflect on that, and maybe they are right. So they quickly noticed that I was very, I don't know if it's the right expression, but a flatliner in expressing emotions. I didn't do that. So they gave me a clock. You see that on the picture hanging on the wall, a clock. I had to hang it around my neck. And instead of figures, it was feelings, so angry, happy, sad. And the whole day long, I had to show how I was feeling. And after a month, they were satisfied, and I could get rid of the thing. And before I had a thing, I always had a poker face, but I lost my poker face after that. It's a learning thing. Don't know the right word. So I want to show share some facts and figures with you. It's impossible to answer, but maybe you have thoughts about how many people have an addiction in the Netherlands. And the answer is 2 million. And our population is currently almost 80 million. And how many people seek help, you think? I was a little shocked when I found out the figures, because it's only 10%. And 70% of the people find their own solution, and 20% of the people with an addiction stay addicted. It's sad but true. And the most common addiction in the Netherlands is alcohol. And the most deadly addiction is smoking. 20,000 people in the Netherlands every year. Alcohol is next with 2,000 people. When you want treatment for your addiction in the Netherlands, you have several options. But before you go into treatment, you have to fight stigma and moral judgment. Because I heard it already from Numan and also Sandra. The general opinion in the Netherlands is that when people get addicted, it's a choice. Or they are not strong enough. The will is not strong enough. We say those are people with a weak back spine. It's a Dutch expression. So you have to fight that, battle that. And when you go into treatment, you hear these two things, and it surprised me. Addiction is a disease, is one of the first things I heard. And I thought, wow, it's a disease, so I can't do anything about it. And then they said, once addicted, always addicted. So why should I do anything about it when I'm always addicted? And of course, after a year or 2 or 3, I understand what they meant. But it's an expression without any form of hope. So I would say, instead of once addicted, always addicted, I would say stay always alert. It's the same message, but it's much more hopeful, I think. Then once you go to treatment, we have a lot in the Netherlands. For youth, for adults, women with little children or babies, whole families, forensics, of course. Numan mentioned Amsterdam, but in several places in the Netherlands, we have the heroin project, where people with a heroin addiction get free heroin 2 times a day. So it keeps them from scoring the heroin and breaking into cars or houses and so on. So it's better for them, and it's better for society, of course. The Minnesota model, 12 steps, are used in the Netherlands, of course. But it's also the biopsychosocial model, because there are biological factors you have to address, psychological and also social. Different kind of treatment, CBT, cognitive behavioral therapy, EMDR for trauma. System therapy was very important for me. I will tell some more about that later on. Running therapy was also great for me. The Berk, as was on the picture, was in a forest, and on Monday morning at 7:30 we had to run through the woods, and it was good. It was nice. And of course, more and more we have expert by experience also in addiction care, and I think it's very helpful. We also have a new paradigm in the Netherlands from the biopsychosocial social model. We are reversing to the recovery vision. To tell something about that. The focus is on cure and healing. Recovery came instead of the medical scientific approach. And in the medical scientific approach, the focus is on cure and healing and symptom control. And when you fight only the symptoms and you get not to the real cause, can you heal? Well, Numan talked about that a little. There's a very fine definition of recovery by William Anthony. Patricia Deegan talks a lot about it. So maybe you can read it. I don't know if the PowerPoint will be disseminated after the webinar, but it's leaving behind your addiction and develop a new meaningful life. In short, recovery is of course a dynamic process. The treatment I got at the Berk in the wood was 10 months, and later on a few years later I was there for 8 months, but now it's only 6 months. And you cannot say that every addiction has a treatment time for 6 months. The one person needs 4 months and another maybe a year, maybe 2 years. So that's a little strange because it's a dynamic process. And central themes in the recovery model is empowerment, taking control, focus on the whole person, shared decision making, involve family and close one. It's an holistic approach and not only on the symptoms or the addiction or the diagnosis. And what we see since a year or two is much more a focus on trauma, because underlying most diagnoses in psychiatry and addiction, various types of addiction, is in a lot of cases trauma. Strange enough, I didn't suffer, strange, maybe happy enough, I didn't suffer any trauma in my life myself. But as you see on the picture is a little girl. And my parents had a daughter and a son. And sadly, the girl, right before she would be 34, she was involved in an accident and died. And at that time, it was 1969, the general practitioner told my mom, get pregnant as soon as possible, because then you have something to look after, to care for. So a month after the accident, my mom was pregnant with me. So she was full of stress, trauma, sadness, and so on and so on. And I learned in addiction care that as a fetus, is that the English word? Yeah. I got that. It went through me. It was in my mother, so it was also in me. So it was not my trauma, but my mother's, and I felt it always. In my family after me came a girl, but talking about the girl on the picture, she was called Linda, was taboo. There was a picture in the room, and at my grandpa and aunts and uncles, everywhere was a picture, but no one talked about her. And that was a little strange. What also was strange is that Linda, weeks before she died, told my brother, our brother, several times, when I will be gone, you can have my toys. So almost as if she knew she would die. And that is very strange. And on top, I said replacement child. It's not the right translation, maybe, but I had to replace Linda. And of course, that's something I can't do. So it's an impossible order to do. And because we didn't talk about it, me and my sister who came after me didn't know what was going on, but we knew there was something going on. My father and mother couldn't deal with the trauma and grew apart, but stayed together for the children. And yeah, that was very noble, but also not the wisest thing to do. They didn't fight, but there wasn't love either. There was a lot of tension always, and we felt that, and we also knew we had to leave our parents as much alone, and when they asked us, me and my sister, how are you? It was always good. So we never shared any emotions, and that was why later on my 30s, I was a flatliner, and earlier I was a flatliner in not expressing any emotions. I learned that as a child. I'm almost done. I talked about the system therapy, and in the year 2000, I was on a 4-week diagnostic group. And there, my father, mother, brother, and little sister came, and we had system therapy. And the problem was clear. It was all about Linda, of course, but no one wanted to talk about her. 2 weeks later, a little, and after 6 or 7 years, after the last system therapy, as a family, we did something for Linda. So we went to the field where her ashes were scattered around in 1969. My parents never went there, but it was the first time in all those years. So after 36 years that we did something together for Linda as a family. And yeah, it actually helped heal all 4 of us, all the rest of us. Yeah, and above that, in general, for me, what worked best was the combination of self-help group. I didn't talk about it, but I was 10 years at the Gamblers Anonymous. Very good. And regular care, of course, to learn a lot of things I didn't know. And the combination helped me healing. So that was that.
Thank you so much, Marcel. Sure. I've written down a few notes. There's a lot to take, and then thank you so much for sharing so honestly as well. You know, it's not easy to just let your history out, you know, and it's such an open platform. You know, the healing that you've had to go through and stuff. But as you say, like, you know, recovery is a dynamic process. I think that's very important to note. It's not linear, and it's not going to go in a straight line. And I think we've got to be aware of that. What I also like your stay always alert. That's also quite important. I like that you've changed it a bit to give it a bit more hope. So that's also beautiful. So thank you for that. And I think something that comes up, or there's a theme, is that harm reduction as well, that you kind of touched on, which is super important, I think, when it comes to a topic such as this, because often, you know, everybody wants people to be sober or better or whatever it is, but sometimes, and I think Elza will touch on this a bit more, but we need to meet people where they are. So fantastic. And yeah, and your family, you know, going through the therapy as well, it's a very holistic journey you've had, and you know, for your family to also be involved in that, it's really great. So yeah, Marcel, thank you. Thank you so much for sharing and, you know, taking the time to put the presentation together. So it's wonderful.
Yeah,
perfect.
Thank you.
Thank you. All right, we'll get to questions at the end. So if anyone in the chat, I don't know if anyone's put any questions up or anything like that, but we will get to that. Okay, we're going to move on to Elza. All right, Elza, you got 2 very hard ones to follow, right? No pressure. No.
Wow.
No, totally kidding, of course. All right, let's jump straight in. So what is your experience with trauma-informed counseling specifically, please?
So I am 23 years sober, but I also struggle with an eating disorder, which is on and off. Do you know what I mean? It's something that you really struggle with because you still got to eat every single day. I worked in the addiction industry in Cape Town for, but also internationally because we coordinate with other facilities for about 19 years. And they follow the model of quite similar. I think it's very much about abstinence, 100% abstinence. And if you relapse or anything like that, there's consequences, quite severe consequences. So that's where I worked in. And then in 2018, I started working in a trauma-informed counseling facility in Cape Town. And unfortunately, I started in 2016. In 2018, 19, we needed to close down because of COVID. But what we found is we did a whole harm reduction approach. So we didn't approach it all about abstinence. And what we did was when the individual came in, we asked them what their goal was for therapy and for what is their treatment plan. So instead of us designing a treatment plan for them and saying, this is what you got to stick to, we asked them. So it became very individualized and very much person-centered. And the whole theme was on building a really good rapport with the client. Instead of it being about we break you down before we build you up, it was we're here to support you no matter what happens. And it's a confidential space. If you relapse or not, we don't care. We want to look at the trauma and we will look at why you are here. And I think that, like I said, it wasn't a one size fits all. And we had the most amazing results. So what we really found was that the trauma really surfaced, and it took people quite a lot of time to get there. And I think what we don't realize, and what I didn't even realize myself, is that, and I think Numan did touch on that, using is nice. Do you know what I mean? And I think we think it's not. Like, if you want to stop, you should be able to stop. People are desperate to stop, but there's a reason why it's there. Do you know what I mean? There's a reason why people use it. Gives them, yes, the escape, but it also gives pleasure, and it also gives relief of pain. And one of the big founders at the moment, Kabul Mate, all he speaks about is why the pain, why the pain. And that's really what we went into. And we looked at the pain, and we looked at if the person needed to use in order to deal with the pain, then that was saying that the pain was a lot. That's just giving us an idea of how intense it really is. And these individuals wanted to stop using. It wasn't like they were enjoying using even anymore. They were really desperate to stop. So we looked at why the pain was there. And we also focused on helping the clients see that they are resilient, that even though they went through the trauma and even though they were struggling to use, they were resilient. There was a ton of compassion in that space. And we were saying we were there to hold the space. We were there to care for them. We're there to be compassionate, and we get they're struggling. And we basically dealt with it as if they were a cancer survivor or a cancer patient. And we were saying, you know, you come in, you're struggling. We don't know what's going to happen. And I think one of the big things as well was therapy is messy. And I think we have this really idea that people come into a treatment center and, you know, yes, it's tough and everything, but it's got to follow an A to, you know, an alphabet. And I think it's quite a capitalistic system we've got going in South Africa, where you've got an A to Z and there's rules in between. With trauma therapy, there are no rules, because you don't know what's going to happen for the person. Yes, you don't know what's going to come up for them. And with the trauma-informed counseling, a lot of people come into the center wanting to stop using, thinking they have no trauma. I mean, that was the big things that we got, where people were like, I don't have trauma. My dog died, my dogs are my kids, but that was my only trauma. And after a couple of weeks of creating a safe space, we were able to see that there was severe trauma going on where that was suppressed. And and I think for me, the big thing was about making the unconscious alive and giving time for that to really, you know, sprout and see what's going on there. So it wasn't just about the conscious and, you know, the impulse or there's a lot of things going underneath, and people are complex. So we can't be fitting one size fits all into everybody and saying this is what should be working. So that was the one side. And I think the big thing for me that that really is, you know, we spoke about it a bit last time, but intimacy. And intimacy, I am finding, I'm still, you know, in 2018, when COVID hit, we needed to close down, but we moved everything online. And we have the exact same, and results for me now is driven about the relationship between the counselor and the relationship the client's able to have outside of the therapy session. And that goes the same for me. It's about my relationships that I'm able to have with people and what that relationship looks like. So intimacy is one of the big things that I'm finding still, and then as well, people struggle to connect. And we keep seeing these things saying the opposite of addiction is connection. How to connect? If someone has been severely traumatized, hurt by their family, how are we expecting them to come into a treatment environment and then make friends? And intimacy is not just about sex, as we know, but it's about having a hug or, you know, holding someone's hand, and I often found that in my, before joining the trauma-informed, that those people would be labeled as having intimacy disorders or having a sex addiction. What we're really looking at there is actually just struggles around trust. So for me, that's the big thing, is just to look at intimacy at the moment. And that's really, particular with the clients and myself, is something that I do struggle with. And I think to make it a compassionate, kind, trauma-informed space instead of a punitive, judgmental space for me is really important.
Sure. Yeah, very, very important points, obviously, and clearly very passionate and well-informed, obviously. I love that, making the unconscious alive. Also very valid, because it's, you know, we do throw around that, you know, it's not sobriety, but it's about making connections. But how do we make those connections, and what does intimacy actually look like? And like you say, it is different for different people, and yeah, very interesting. So I would love to hear more about that. Maybe we can do a follow-up webinar on intimacy and human connection or something along those lines. I think that would be great. All right, let's move on to the second question. What has been your experience with treatment centers, specifically in South Africa?
So, I mean, I've been thinking about this more and more, even since our last meeting. I actually spoke to my own therapist about it, because I do believe there is a place for the model that we do have in South Africa. And I don't really want to badmouth it, because I did come from that own model myself. But I do feel currently, with what's going on, in particular in South Africa, regarding our trauma rates and our sexual assault rates, that it's not working. And one of the reasons I think it's not working is because we're putting so much focus on abstinence. And we're saying that if someone's not abstinent, they have relapsed, and their clean time goes and their connection's broken, and we threaten that connection. And we say, you know, family's going to cut you off. This is what's going to happen. When we're actually not looking at the fact that if the person has had a slip, they're actually really struggling. Something has triggered them. Something bigger is going on, and making it a non-punitive, and rather than making that a secondary issue instead of the primary issue. And my experience of working in the centers in South Africa, I struggled, and I struggled working in it because, well, at the time I really believed in the system, and it still is happening the way it is now. And I think it's really sad. And because it's an abstinence system, people get admitted. And my concern with that admission is the fact that we are currently aware that in South Africa, we have a 40% chance of a relapse and a 60% chance of readmission. So we're admitting people into treatment centers knowing that they probably will relapse, or there's a 40% chance that they could. And then we're telling them to stay abstinent. And we're also telling them that if they do relapse, any connection that they made in the time that they were treatment will be broken. They're not allowed to have contact with the people that they made friends with in the treatment. And a lot of these people are desperate to stop. So they're not coming in and intentionally relapsing. They're coming in and it's happening almost unconsciously. And we're saying, like Marcel said, it's a choice. Like we're saying they had a choice and they shouldn't have made that choice, so they have to leave. And I'm also concerned that we're saying that they have to be kicked out if they relapse, knowing that there is a 40% chance that they could. So we're kind of like setting them up almost. So that to me is very concerning. And then I phoned around recently some rehabs just to find out what is it still the same? What is happening? And nothing has changed. And the rules have actually just gotten stronger in the sense that now we've got sniffer dogs and police coming in and arrests are being made. And I mean, this treatment centers have been going for 30 years where people get chained up and locked down. And, you know, those systems are still in place and people are paying between 50 and 100,000 Rand for 28 days to be in these facilities because they are desperate to stop using. So for me, I just feel like it's quite a capitalistic system that we've still got going. And I feel like if we introduced more of a harm reduction system, which is currently what we do on an online platform, which means that people don't actually have to even be admitted, which is a lot more cost effective. And looking at the trauma and saying that, yes, in a country where 1 out of 2 women are raped, we're saying that the chances of that person having a substance abuse problem, but they're more being, you know, more about stuff going on underneath is a lot higher, is something that we should be looking at.
I've definitely, since we started prepping for this webinar, and you know, through a lot that the 3 of you have spoken about, I've thought about a lot of the stuff, and this harm reduction thing has really stuck with me, because it is, if you look at it from an outside point of view, treatment is always seen, you go in, you don't do anything afterwards, and that's it. That's your only option. Like you said, it's very capitalistic, and this is the way it is. And now you're saying it's even worse because there's sniffer dogs and cops and such getting involved. And I think, I mean, if we kind of, you know, take on almost, if we could in an ideal world, kind of take on the Portuguese approach and look at it as a health problem and also kind of intertwine, you know, meeting people where they are and looking at it from a trauma informed position and from a harm reduction, you know, in some world, that's a perfect marriage, the way I'm looking at it. So yeah, but thank you for phoning around and, you know, doing some research for us South Africans as well. It's good to know, you know, what's still happening out there in terms of, you know, treatment centers, etc. All right, let's go to the last one. What is your personal experience with addiction, and what do you believe is the most effective treatments? I know you've kind of tapped on it already, but just to kind of explore that a bit more.
Well, I do feel like, I mean, I completely hear you, Sandra, saying that there is this perfect fit, but I don't think that there's a perfect fit for anyone. And I think it's quite interesting because Marcel's fit and my fit and Numan's fit is 3 completely different fits, but all 3 of us it's worked for. So I think it's got to be about where the person's at and discussing with them trial and error as to what would happen best for them. I was put in a 12-step facility, and I went in with a lot of trauma, and I really struggled with an eating disorder and substance abuse and alcoholism. And I went in at 19, and I was really, really lucky because when I went in, I was too young to do a lot of the 12-step work with. I didn't really want to go there. They wanted to focus more on trauma. But I actually spoke to a friend of mine recently about it, and he's pointed out something quite important. And part of when you go into the 12-step facilities in South Africa, and they still work like this, you get collateral letters, and those letters are written from family members, and they put all your shame out there in a group. So everything that you ever did badly during your addiction gets read out into a therapeutic group with your peers. And then that's discussed, and you're shamed and, you know, feel terrible. And I never got a collateral letter. However, I could always relate to the trauma that the families went through. So I think for me, what was happening is it triggered a lot of my own trauma. And so I was able to deal with it. And they didn't quite know what to do with the clinic because they were like, you're too young. And is it, you know, what's going on? And then a lot of the older people in the clinic that were like in their 40s and 50s were like, you've got to do this. You're young. You know, we're 40 and we've, you know, it's happened our whole lives. So yeah, that was my experience. But I also feel that, you know, I had peer support. So similar to Marcel, I had made really good friends, But then I also had an amazing counselor. I had an amazing counselor that I met when I left treatment, and he's been incredible. And I built a really good relationship with him where there were boundaries that were gray instead of it being black and white. And I was able to function like that. But I also learned a lot about intimacy. I was sexually abused when I was little, which was something that was a really big trauma for me, which I only discovered when I was 3 months into my treatment. So that only surfaced then. I had no idea it even happened. Yeah, which is why I think my passion is there for the trauma model. I feel like it really does have a place. And I feel like if we were able to answer the phone to individuals that were struggling with trauma from age 12, 13, 14, we would have a much higher success rate regarding substance abuse as well, if we just dealt with the trauma earlier on.
Absolutely. It reminds me, I'm going to speak a little bit out of hand at the moment here, but years ago I did a workshop about trauma, but it's years, so my memory is a bit fragmented. But one of the things I remember is when they spoke about when you need to get trauma is within, it's close to the actual date that it happened. So when you refer to like the age, as if we could get the, if we could reach people at a younger age, that would be ideal, I suppose, in many ways, if I'm reading or making the right correlation between something I heard years ago kind of as well. All right, let me open up the floor just to see. Zach, did we have any questions from Facebook? I actually haven't been checking the chat if we've had any questions or anything on there.
Zach's present. Oh, he's back.
I'm sorry. I said that we haven't had any Facebook messages yet, Sandra. Unfortunately.
Okay. And then I think we've just had a few comments on the chat. So yeah, I think let me at this point if anybody wants to ask a question, you're welcome to put your hand up. It's obviously a safe space here. You don't need to put your camera on or anything like that. But if there are any questions, please feel free to ask.
Sandra, just Manjula had her hand up.
Oh, okay. Sorry, I can't actually see the full screen. Let me try that.
Open my video if yeah.
Oh, there we go.
Yeah. Hi, Sandra. Hi, everybody.
Hi.
When I was listening to the presentation by Marcel and then the second presentation, I was just thinking about my life and my family life, because my older brother, who comes from my first mother, my half brother, he's gone into alcoholism a lot, and it really gives a lot of trauma in our family. And I was just thinking that how do we deal with it, because I'm not able to visit my family like very frequently because I live in another city, and it's really painful for me to go and meet him, because he gets like the situation where it's out of control and there's a lot of heated arguments, and it's really difficult for us to handle that situation. Although I am a human rights lawyer, but it's very difficult when you are doing that work outside your family, and when it comes to your own family, the trauma which it brings, and it's really difficult. And as I was listening to the other presenter, I'm sorry I've forgotten the name, but yeah, I'm also a survivor of sexual abuse at the age of 4. So see, sometimes this trauma comes out in a different way. Like even I'm not able to understand, because I didn't go for any therapy, because in Indian context, it was never seen as something like, because the child would not even reveal that she's been sexually abused most of the time during my generation of, like, I'm also 53 like you, Marcel. So it's like a very difficult situation for me. I have overcome that pain and trauma, but it's there in your unconscious mind somewhere, and it holds you. Okay, it does give me some kind of energy and to help the survivors of sexual violence, but it also keeps me holding a kind of a trauma, not that kind of trauma, but a kind of a pain which always remains in me. And I think I just want to understand, how do you, I don't do any substance abuse. I'm not like, I don't smoke or I drink alcohol and nothing. But I just want to, I meditate. I try to heal myself through meditation. And so that's how I am able to work on myself, because I do a lot of capacity building and leadership building of grassroots activists who work in a very different situation. So I just wanted to understand, because it or the cultural context, like what it's been written in the chat box also, that the cultural context of each of our countries are different, our regions are different. And how does trauma is seen in the context of India vis-a-vis Europe and also in Africa. So that's also something we need to debate and discuss about, that what are the areas of intervention, how do we deal with those kind of traumatic situation, because the healing is so important. And I don't know how to work on these situations, but I do come up often to these kind of situations. But my personal life with my brother, I really I am traumatized with that fact, that how do I relate with him, where we don't hurt each other, or I don't hurt him. I don't want to, but the only ways I escape from that situation is I don't meet him.
Thanks. Thank you so much, Manjula. I'm going to leave that to the panel. I don't know if any of you want to give some feedback on what Manjula has asked.
Is Marcel unmuted? Numan.
Marcel?
Yes, I can say something about it.
Thank you.
Because it's a question often asked by relatives from people with an addiction. And it's a very difficult thing to answer, because the logical answer is leave him alone, set your boundaries, tell him what you want and don't want, and let him go. But it's your brother, so it's I think you love him. So that's very difficult. I don't have a very good answer for that. What worked for me the best is when my parents told me, because they saved me a lot. I could always lend money from my father, especially. And after years and years, they said, Marcel, you are always welcome. You can come to eat with us, but we don't give you any money. We don't give you any groceries, and we don't want any weird behavior. Then you have to go. In the first 2 or 3 days, I was very delighted, because they always used to call me, where are you? Is it going well? And the fourth day, I thought, hey, where are they? So it worked when they set their boundaries. So that's what I can say about it.
Thank you.
Thanks, Marcel. Do you want to chip in, Elsa? Do you have any thoughts?
And I can relate to Marcel. So I have a similar thing, and I think that there's two sides to it. Like you need boundaries for you in order for you to be safe. Do you know what I mean? Because the behavior is, you don't know what you're going to get. But I actually just today spoke to somebody else that's struggling with somebody that has addiction, and we were brainstorming as to what, because every person that struggles with it is different. And for me, the thing is to say, I love you. I'm here for you. You're my brother. But I can't be around you when you're drinking, because it triggers me and it makes me feel unsafe. Do you know what I mean? So it's like, I don't know if you can do that, but I think like it's short and sweet, and it's like, I'm still here, but for me, it's not good. Do you know what I mean? Because I think if we make it about you're bad, you're terrible when you're drinking, it misses the whole point. And it brings the stigma back into reality. So that would be my suggestion. Because there's still a person there. And I think that for me is the big thing. Like, addiction's not the whole person. There's so many complex layers to it. It's just their soothing mechanism, and it unfortunately sometimes makes them into a terrible person, make me into a terrible person. I'm sorry.
If I can offer something from a cultural perspective, that's the thing. Because Manjula, you're from India and I'm from Bangladesh, say the India subcontinent, saying you love him and what have you, my siblings tried that, well, the siblings that did know, when they tried that with me, and well, to be honest, that does not work. Coming from that subcontinent, saying you love him and all that, the idea of love and, you know, what have you, in our subcontinent, it's more of a manipulative tactic. It does not work. It kind of doesn't work. You've got to talk to him and talk to him about what has he accomplished by being a drunk? What are his peers doing? What has he actually done with his life by being this drunken person? How much of his life has he wasted? You've got to bring him back to earth by showing him how negatively it's impacted his life. And it is, and I can't lie to you, it is going to be hard for you to say this to him, and he's not exactly going to react very fondly of you when you tell him he's done things badly. So, you know, maybe do it from about a meter away so that you can run away quickly. Because that's how I've reacted. But it's something you'll have to do it a couple of times. And then sooner or later, it does sink in, because he's obviously doing the drinking to escape. But once you say those words, it's going to become part of the words he's going to try to escape from. But he can't escape from those words, from someone who is his sister. And siblings and family ideology stuff in the subcontinent is very big. It's massively emphasized. Your words are going to be like a massive plane going off in his head. It's not going to stop. You've got to talk to him and tell him, what are you doing with your life? You could have done so much. It's not going to be fun for either of you. But when he comes out through, it's going to be better. So I am really sorry what you're going through. I can't say I'm sorry for him because I don't really know him. Sorry. So just keep at it.
Thanks,
Thank you,
Numan.
Manjula. Yeah, thank you for such a powerful question. Go for it.
I just wanted to add, Manjula, about the sexual abuse. I think for me, one of the big things that has really helped me is being able to create space for that. Do you know what I mean? Instead of like pushing it away or saying I can't deal with it at a moment or saying it's too much, just creating a space for it. And if that means lighting a candle and just spending 2 minutes a day, you don't even have to think about it, and just saying, I have compassion for myself for what I went through. That's it. Do you know what I mean? And taking that time, and I don't think we give ourselves enough permission to cry. And crying is the best therapy in the whole world, and it's free. So put a candle on, give yourself permission. What you went through is terrible.
Thank you.
Powerful stuff. So I'm just taking over as Sandra's switching inverters because of our electricity issues in South Africa. But Manjula, I think, you know, taking into consideration what each one of our speakers have said, because this comes from lived experience, so they do genuinely understand. And I think it's so brave of you as well to have asked, because they're not coming from a therapist point of view, or they're coming from, this is my experience and this is what worked and didn't. So thank you again also for asking. I think that was a good question to ask. Thank you. Does anyone else have a question? Maybe ask. I know we're over time, but I think this is important space. If you guys don't mind a few minutes longer. Anyone has a question or a comment even? Okay, so I believe the next part of the webinar was going to be handing over to Theo to be giving us a little few minutes of her words. Theo, are you with us?
Yes, I'm here.
Great.
All right.
Yeah. So if you can, like I just said, I'm jumping in, so I hope I'm not derailing the structure. So
right.
If you can carry on.
Okay. Let me not keep everybody a minute longer. I just want to really sincerely appreciate the participation, especially of our speakers, your presentations. They were really very informative, engaging, and thought-provoking. It was also clear that you have put a lot of thought and preparation into your talks, and we really appreciate that. I'm impressed with your practical insight into the topic, your years of experience that you've shared with us, the depth of understanding of the topic, and the ability really just to share the key concept and practical ideas in such an interesting way. Thank you, really, guys, for your willingness to share your expertise with us. We hope that you come back as speakers in future again. And to Sandra, hopefully she's back. I just want to say thank you for navigating the conversation so well. I appreciate your sense of humor and also your unique ability to put the speakers at ease. And for everyone who joined us this evening, we appreciate you being with us. And we hope that you have enjoyed it, you have learned something. And yeah, cheers from me. That's it. Thank you.
Sandra, over to you. I can see you're in the dark now. But just quickly, maybe to add, I think, just to let everyone know, Theo is the chairperson who was running sort of this activity from the start. So thank you to you too, Theo. Don't just thank everybody else. Thank you to you too. But I'll hand over to Sandra.
Okay, thank you. Sorry, yes, I'm in the dark. I'm getting ready for Christmas, it seems, but yeah, no, we have power issues in South Africa, so we have to play musical Where's the Lights. So yeah, I'm a bit sad I missed the end of the conversation there with Manjula. I'm not sure. I'm sure everybody, gave words of support and encouragement, and also from my side, just sending you strength and love. There's no right answer. Sometimes we've just got to go with our heart, even if our heart may, sometimes it hurts, especially with the people we love, and things like that. So just from my side, just sending you lots of love and strength to you and your brother as well. Hopefully that all settles a little bit. But yes, just from my side, thank you, Theo, as well. Theo has been is an amazing chairperson, and I really appreciate all the work that you've put into today's webinar as well. I'd like to thank Claudia for coming as well. She also took the time. She's got a very busy schedule, and really appreciate that. And most importantly, let me not forget, of course, Zach. Zach does all the tech work, and much appreciate you, Zach, always. We wouldn't be able to do all these streams and such without you, so thank you. And then obviously to the presenters, I love doing these things because it's just to learn from the expertise and the experience and such as well, but also just to feel your journeys as well and your experiences, and also learning and to see what's happening from a global perspective. And this is a very important topic, obviously, because it is something that needs to be cracked open within the mental health space as well. So thank you very much, and well done to everyone, and thank you for everybody who took the time to attend tonight. And that's me. An early Merry Christmas, I suppose, and yeah, we'll see we'll see you again soon. Thanks, everybody.
Thank you very much, guys. Appreciate it.
Thank you.